Cool. Great. Thanks.
All right, without further ado, let's welcome Dr. Brown.
I'll start by apologizing. Thursday I had my winter tires taken off my car. So I was slipping and sliding all the way over here today. It's going to be an interesting drive home. I also apologize for the fact that on that picture of me earlier, I'm wearing the exact same tie. I have like 100 ties. I wear the same one today a year later. It's funny. Mike Brown. I'm a gastroenterologist at Rush. My area of expertise is functional GI disorders. I mostly work with people who have abnormalities in neural signaling in the gut or motility disorders, which is why I have the majority of the Scleroderma GI patients are in my clinical practice. Take care of a lot of functional bowel disease too, like irritable bowel syndrome and such, but my Scleroderma patients have a little higher morbidity from their GI disorders and require a little more sort of TLC and attention, I'm afraid. So I'll go over the GI illnesses. It's important. It's 95% of people with Scleroderma will experience a GI manifestation. About 10% will present with the GI manifestation as their initial sign that they have Scleroderma. We often find that in some of our patients who have severe reflux disease. We just can't get their reflux under control, even with very aggressive use of proton pump inhibitors. And we start studying things, we find that there's a significant, very classic motility abnormality in our patients with Scleroderma. It's unlike any other type of motility disorder, so we make that diagnosis often in the motility lab. So prevalence about 240 per million, men much greater than women, so my clinic is mostly women. Ages, again, we mentioned that earlier, it's about 35 to 65, so I see quite a range. Cause. Let me tell you a cause. Oh no, chemicals, exposures, genetics, everything in the world is going to turn out to be our genetics and our environment, and they mix together in a bad way in some situations. As we work through a lot of diseases that I thought were other issues, they sort of turn into a lot of genetics and a lot of environmental exposures. A lot of viruses are neuropathic in origin, can lead to long-term damage. Just interesting looking at things like Alzheimer's, which I think may be a herpes virus issue. So I think somehow down the road it all distills down into that. To give you a little idea about how we're interacting with bacteria and Scleroderma, there was one clinical trial is underway in Oslo, Norway, looking at fecal microbiota transplant. That seems to be the answer to every disease these days. We put somebody else's poop into you and your diseases leave, and I guess you get their diseases. Gotta be careful. I have a lot of patients interested in that because there's a lot of buzz at Dr. Google about FMT for about everything I treat, including Scleroderma patients, and it's intriguing enough that there is now a clinical trial underway in Norway looking at fecal microbiota transplant, and I'll mention some of the new drugs as I get down the road. I do want to caution you about one thing, is that when you take somebody else's fecal material and you put it into you do permanently change your fecal microbiota, and you might be picking up things that they had. For instance, when we do fecal microbiota transplant for a condition called Gastrointestinal difficile, we look very carefully at the individual donating. They can't have underlying disorders. They can't be obese. They can't have arthritis. There's a whole lot of things that have to be ruled out. As a matter of fact, you get paid to be a stool donor, about $40 to $50 per sample by Open Biome. So a lot of people are interested in that. Getting paid for your poop's a pretty good deal. However, they have hundreds of applicants. Only 3% make it through their screening protocol. So it's a very selective group. But I'll mention a little bit of that down the road because it is intriguing, and we are looking at it in a variety of autoimmune disorders. Because a lot of what drives your immune system, obviously, is exposure to organisms. And if you've got a revved up immune system and it's cross sort of reacting with smooth muscle, then you might get into trouble. So, looking at FMT in the situation of Scleroderma and other autoimmune disorders actually kind of makes a lot of sense. So there are these blood vessel abnormalities that are sort of the bottom line, sort of foundation of getting into trouble with this disorder. This leads to local tissue oxygen loss. This leads to abnormal repair with excess fibrosis. And in the GI tract, leads to scarring and tissue replacement. So in the skin, it's obvious. In the GI tract, maybe not so much, but the consequences of it are obvious. So your big tube, right? So from mouth to anus, it's just for big donuts. There's a big hole running right through the middle of us, but a very specialized one that has lots of sort of special features and activities. The simplest way, I think, to think about the GI tract is, I'm going to skip the old anatomy one here. I'm going to go to this one, is you have transit organs and you have storage organs. Your esophagus is a transit organ. When it gets into the business of storage, you get trouble. You can't swallow. So let's say you have severe esophagitis from your scleroderma, you scar, you obstruct, things get stuck in your esophagus, and you develop something called dysphagia, or difficulty swallowing. As long as the peristalsis, or the motor activity in your esophagus, is moving nicely, it does its job as a transit organ. The typical transit time in the esophagus for something you swallowed this morning is about 4 to 5 seconds. It doesn't spend much time in there. Then you hit the stomach. The stomach is a storage organ. Mostly it's a mix master. Its goal is to accommodate. It stretches out when you eat. The top part of your stomach accommodates all that food, and then it slowly doles it out into the bottom of the stomach, where you have a mix master. You have something where the bottom of the stomach is kind of a blender, and it grinds and grinds and grinds and grinds the food until it's very tiny and basically liquid almost, and it squirts out through the pyloric channel into the small bowel. So basically, when you eat solid food, everything that should leave your stomach should be liquid. And I've always laughed at my surgeons who, patients who have colonic or small bowel disease, they want to give them liquid diets. I said, if your stomach's working, everything's turned into liquid. Nothing leaves your stomach that's solid. So it's a little bit of an odd sort of approach to things. Small bowel, transit. 2 hours in and out. So once it hits the small bowel, it should be a nice 2-hour sort of ride through 22 feet of small bowel and into your colon. Colon storage, where things stick around until it's socially acceptable to have a bowel movement. As a matter of fact, you sort of think of your colon as sort of pushing things forward and out. I mean, it's supposed to help you get a bowel movement. The majority of the motility in your colon is to push backwards, to keep you continent. Particularly at night, the colon pushes back a lot because you don't want to get up in the middle of the night or actually end up soiling the bedclothes. So the colon's very active in pushing everything back, and it acts as a storage organ. So a couple of things can happen problematically in patients when these organs take on either too much of a good thing or don't do what they're supposed to do. In the esophagus, again, scleroderma patients get severe esophagitis, and that can become a storage organ or a storage space if there's a stricture or narrowing at the base of the esophagus. In the stomach, it's supposed to store things, but the main problem in the stomach in scleroderma patients is a process called gastroparesis. You've probably heard of that. Gastro, stomach, paresis, slow or weak. So weak stomach emptying. So it stores stuff. It stores it forever. The typical stomach emptying rate should pretty much empty in about 2 to 4 hours after you eat. If it's sitting there for a day, obviously we've got an issue, too much storage. There are issues of rapid stomach emptying, but those are really not germane to scleroderma. Big problems when the small bowel starts to be a storage organ. Probably the single biggest problem I have that requires the most intervention in my scleroderma patients is small intestinal bacterial overgrowth due to stasis and slow transit. The small bowel is sterile for the most part, and the reason for that is because of rapid transit. Things are just moving through there. Bacteria have no chance to set up shop in your small bowel. However, when things start to slow up, we'll talk about the consequences of that in a few minutes here, you get into trouble. And the small bowel will not empty. It sits there. Bacteria overgrow. Bacteria, for the most part, the ones that grow in the small bowel aren't particularly pathogenic. They aren't damaging. It's not like salmonella or something. They're your colon bugs moving north and taking up residence in your small bowel. It's just they compete with you now. The food you would absorb in your small bowel, leaving very, very little for them in the colon, now becomes, they're having a field day down there. That's like free lunch way up high. And so they're fighting with you for your nutritional support. So they'll steal your B12, they'll take your folic acid, they'll take your water-soluble and your fat-soluble vitamins like D and vitamin A, and they'll take your other nutrients. And you'll get malnourished because you're fighting your own host flora for your nutritional support. So that's a big problem, and we work a lot on that. And then there's the colon. From the standpoint of the most annoying side effect, I think, of scleroderma in the gut is probably constipation. Very severe constipation, a lot of fecal retention. It can lead to an odd thing called paradoxic diarrhea, where there's so much fecal retention in the colon that the only thing that can get around the impacted fecal mass in the colon down here is liquid stool. So patients come in and say, I'm having diarrhea. I'm having 7 bowel movements in the morning. They're having very small bowel movements. Just a little liquidy stuff gets out. When you do an x-ray, it's full of fecal material all the way around. It's a bad fecal impaction we have to clear out. So we work very hard on keeping the colon moving and up and running. And we'll spend some time talking about there's actually some new approaches to that that are kind of handy. So almost any part of the GI tract can be affected because your entire GI tract, right, is full of smooth muscle, this special kind of muscle that makes the gut move. So it's basically a big, long muscular tube. And if you damage the blood flow to those muscles, they get fibrosed, they drop out, and you end up with abnormal gut motility. So from the oral cavity all the way down your anus, you can get into trouble. It can be slow or rapidly progressive. Mostly it's fairly slowly progressive. I will mention a little later on that the liver is involved as well. It's one of the solid organs of the GI tract, but it's very rare, only about 1%. We'll talk about that disease in a minute. So let's grade the involvement. So grade 0, just a blood vessel injury. These patients aren't having much trouble yet. Everything's pretty much moving fairly well. May have some abdominal pain though, but that should be about it. Grade 2, now we're starting to get into trouble because we've lost blood flow. The nerves get damaged, they don't work as well. We're starting to see motility issues now in these patients, maybe mild, little heartburn and a reflux. They may come to me because they've tried the over-the-counter Nexium and Prilosec, and that's not really working for them. And then grade 3, now you're getting a muscle injury. Now you get into difficulties with inability to close off the lower esophageal sphincter valve so that the acid can flow up very easily. You might be getting into difficulty with severe constipation at this point. And then you get on to grade 4 where there's actually scarring, and here's where you can get some severe enough scarring to get a stricture in the esophagus so that we have to dilate that because you can't swallow. Might get a stricture in the small bowel. That's luckily very rare. So on to some specific sites. So here's our stomach. Stomach's pretty, so things move through the esophagus. You get what's called peristalsis, so your esophagus senses something up here, and then it squeezes itself like an adult squeezes a tube of toothpaste from the bottom down and it goes right on through. When you start getting motor disorders in the esophagus, they can manifest as weakness. So there is no pump function. It just sort of sits there and drains out of the esophagus by gravity. Or you get odd sort of contractions, sort of the way your kid might squeeze a tube of toothpaste. Just grab it anywhere. Some squirts up, some squirts down. It doesn't work really well. Most of the scleroderma patients go through a process of getting altered motility with this kind of weird non-progressive, non-propagating motility, and then it moves on to a very weak situation in which when we put a motility catheter in there, you don't get any movement. It just sort of sits there, and when a patient swallows, nothing much happens. The bolus moves through sort of by gravity. As I mentioned, when you get to the stomach, there should be this accommodation. Stomach should stretch out nicely to accommodate the food you ate. The stomach can stretch to anywhere 4 to 5 times its size. And when it gets all stretched out, then you start to feel full and you'll stop eating. And then the stomach will slowly dispense that material into this part here called the antrum, and there's lots of grinding, as I mentioned, that takes place there, and then it doles that out over a few hours into the small bowel. That process should take place in, maybe about 4 hours, 5 hours at most in a stomach. Shouldn't be much in there after that time. If it is, then we make the diagnosis of gastroparesis. So, if there's a low valve pressure between your esophagus and your stomach, if that valve isn't tight, when the stomach goes to squeeze, some material may move out of the stomach, but some moves up into your esophagus. And moves up in the esophagus, then you get heartburn, you get acid reflux. You might feel burning, you might feel a sense of distension, you might have it come up into your mouth as regurgitation, so it can be pretty unsettling. There are things you can do that make it worse, right? You bend over because you're picking something up. Exercise can increase it. Sleeping at night, I'm not sure if you lie down at night. God help you if you eat right before you go to bed. Nothing like filling up the stomach and then lying flat. Take gravity out of the situation. You have a weak valve. Now it's just going to flow back and forth. And there's no drug on planet Earth that's going to stop that. That's gravity. That's physics. I can't fix that. You can fix that. Don't eat within 3 hours of going to bed. There's the single most important thing you can do with acid reflux is not eat within 3 hours of going to bed. No matter what drugs you're on, no matter what else you do, that's super important. There's one other little trick that most of my refluxers, so if you have acid reflux, you probably already know this, maybe you don't know why, but if you sleep on your left side, you're going to be much better off. Lots of studies have shown that there is significantly less acid exposure if you sleep on your side. If you sleep on your belly or your back, what I call a turtle starfish, I have some weird name for it, but that's neutral, not helpful and not bad. Do not sleep on your right side. Do not sleep on your right side. If you sleep on your right side, your stomach's up here. Your esophagus is down here. Your acid goes right in, right? You sleep on your left side, your stomach's down here, esophagus up here. It has to climb. It can't. So when you sleep on your left side, you do great. Matter of fact, if you're interested, and you can, I've tried this thing out. It works, but it's a little weird to sleep with. It's called a Medcline, Medcline. You can find it online. It's kind of interesting. It locks you into a left lateral decubitus position for sleeping at night. You slip your arm through this thing so you're not crushing your arm all night. And it tilts you also at 30 degrees. So it puts gravity in your favor. So tilt you 30 degrees, put you on your left side. It's got this other little kind of weird pedal thing that comes around you that holds you in there. So you're locked in. If you like to move around a lot at night, you're not going to like this thing because you are locked down. But you will stay in the most advantageous position for reflux at night with this thing. I think it's a little expensive. It's a couple $100, but it does work if you can deal with it. But you're going to sleep in that lockdown position. Usually affects the bottom 2/3 of the esophagus. This is one of my Scleroderma patients who came in to see me. That's a pinhole. That should be about that big. It was tiny. That took me forever to stretch open. Men are funny. Men will put up with things. I've never had a woman come to me with a hole like this. Only guys. Guys will put up with stuff. It's like, well, a couple extra cans of beer and I got the hot dog through. But it's like, it's probably a little, you wait a little. That took months to get that stretched open because there's only so much you can stretch it at a time. My women patients who make up the majority, they come in very early with dysphagia, and we can get on it quickly and get these things opened up so they don't cause trouble. The nice thing about these strictures is once I blow them open with a balloon, I stretch them and crack them. As long as patients stay on good acid suppressive therapy, they'll do fine. They actually really don't recur. They're pretty easy to manage, but they're very dissettling. I mean, when food gets stuck in there, sometimes, I'm unfortunately on call today, but I come in a lot at night for food impactions where, something gets stuck in there, and that's really dissettling. The people can't swallow, can't handle their saliva. You got to go down there, dig out the chicken or the hot dog or the kielbasa, whatever's in there, and then open it up like we did that guy up there. I think that's actually, that video might be, I think it's one of my food impaction patients, and so it's kind of a bloody mess. So I don't like doing those in the middle of the night. But yeah, yes, by the way, if you have dysphagia, food is sticking it all, see somebody early. Get this addressed early. It's so much easier when it's mild than when it's severe and food impaction. So here, acid is getting up into the esophagus where it doesn't belong. You can see on the little inset on the right, that material sort of sits in the stomach. And actually, a lot of accommodation occurs up in the stomach. And so therefore, there's a lot of food up there to come up if that valve is loose. So we want to try to avoid that. I will give you a little bit of a hint on what we can and can't do with reflux disease. So when we give you, I have acid reflux. I've been taking proton pump inhibitors since 1989. If I don't take it tonight, I'll have acid reflux. If I take it today, I won't. It's that simple. It's a disease we treat, we don't cure. There's been a lot of noise about long-term use of proton pump inhibitors. 95% of it's noise. 95% of it is an association. Associations are like, in the winter, birds fly south, and it must get cold because the birds take the heat with them. No, that's not cause and effect. Birds don't make it cold because they fly south. That's an association. It's not cause and effect. To date, almost all of the things that you've been tortured with about long-term PPI use on the web are associations only with no data supporting cause and effect. I will go through the things that have not been shown to be actually a cause and effect with PPIs. Osteoporosis. I've had patients with scleroderma pulled off their proton pump inhibitors because their primary care doc said that's going to cause your bones to rot out. It will not. Then they got a stricture. Then I had to dilate the stricture. One guy who had it ended up on the aspiration pneumonia in the hospital because he stopped his PPIs without talking to me solely on the basis of someone scaring him about osteoporosis. So the study in Hong Kong 10 years ago, suggested it. The studies since then have shown that it is not caused by the PPIs. That is not an issue. Alzheimer's, not only associations, no cause and effect with Alzheimer's. Taking your Nexium will not cause you to get Alzheimer's. That's simply not the case. C. difficile infection, community-acquired pneumonia, none of those have been shown to be cause and effect. The FDA only recommends a couple of things with long-term proton pump inhibitor use. One, check a yearly magnesium level, because it comes in some people with special kidney issues that can lower your magnesium level, and check your kidney function once a year, which probably almost everybody in this room is doing if you're seeing a doctor. That's it. Check your magnesium, check your renal function. And even those issues, sort of an allergic reaction in the kidneys called interstitial nephritis and hypomagnesemia or low mag levels are very rare. 1 in 1,000 or so. With the mag levels, we just give them extra magnesium. Don't have to stop the drug. So, particularly with scleroderma, it is so dangerous to not have acid reflux controlled. It increases the risk of esophageal cancer. It increases the risk of laryngeal cancer. It increases the risk of stricturing. There's actually several studies showing progressive of lung fibrosis in scleroderma patients with poorly treated reflux disease. You got to have primary care doctors taking patients off for a presumed issue with Alzheimer's in a totally healthy 35-year-old whose lungs are being destroyed by acid reflux. That is unacceptable to me. And this is why I go so nuts about the internet sometimes, because these things sort of get a life of their own. And without any data and literature supporting it, people start to act on it in ways that is detrimental, particularly to scleroderma patients. So, a question over there, I think? Yeah.
We have a question about the PPIs.
Mm-hmm.
You say no effect with osteoporosis or
Correct.
whatever. But now, say like you're introducing steroids. I was on prednisone for
Yeah.
a long time. And now I do have osteoporosis.
Right.
And I do have PPI.
Right.
So it could have been caused by one or both, or
One.
now does the PPI
Steroids, not
make
PPIs.
osteoporosis potentially worse,
Yeah.
even if it didn't cause it?
Now, so I'm going to go through the story of osteoporosis, and PPIs. 10 years ago, Hong Kong, study published. Let's look at women who are taking PPIs and hip fractures. In Hong Kong, not the United States, but in Hong Kong, they find that there seem to be more hip fractures in women taking proton pump inhibitors. And so it goes out, well, that must mean there's more, again, assumptions, presumptions. That must mean there's more osteoporosis. So this gets out, gets a lot of press, because to keep you tuned in, news channels like to say, oh, here's a commonly used drug that you're probably taking. We've got something scary to tell you about it after this commercial break, so stay tuned. So there's a lot of press about it. Since that time, there have been 5 cause and effect studies done. Cause and effect meaning you look at this prospectively in a controlled way, not just an association study, where they tried to look where there are confounding factors, where there are things that osteoporosis patients who are taking PPIs do that might make the osteoporosis worse without blaming the PPI or some other issue. What they found out is, guess what? The drugs used to treat osteoporosis cause heartburn. So what do people take when they get heartburn? PPIs. So if you look at PPIs, because a lot of the people who take them are taking them because the drugs treating osteoporosis cause heartburn, it looks like there's an association. There is. Because the drugs we use to treat osteoporosis, Fosamax, Relaclast, all these things cause heartburn and reflux and esophageal damage. So people either from their physician or they go to the grocery store and they get these drugs. The confounding factors was that the drugs used to treat osteoporosis caused heartburn. So when you look at it without looking at this drug class that causes heartburn in the middle of the issue, yeah, it looks like a lot of people who have osteoporosis are taking PPIs. That's the hazard of association studies. That is the absolute reason that you have to be, with a lot of information available to you guys, you have to be a little bit attentive to how you consume that medical data. If you look at most of the studies where they have associations, the authors at the end, you have to say what's wrong with your study, what might be a problem. And they will say, this is an association study. This does not prove cause and effect. A study needs to be done proving cause and effect. Those are harder to do. They're expensive. They're complicated. I can today go back to the office today, pull up my EPIC data, and I can do association studies till the cows come home. I can sit there and say, oh, let's see how many patients on PPI get this kind of diarrhea. Or let me take all my scleroderma patients and see how many of them are using probiotics and see if that makes any difference. Those are cheap, easy to do, only dry lab, i.e. data-driven studies. They're not the hard studies. For me to do a study properly on FMT, let's say, or probiotics in a scleroderma patient, I would have to take a whole bunch of you guys. I'd have to take half of you and say, hey, guess what, you're getting placebo, but I'm not going to tell you because it's a blinded study. I'm not going to know you're getting probiotic, and you're not going to know. You're going to get a sugar pill for all I know. The other half, you're going to get the drug. And then we're going to go so long, we're going to have reasonable endpoints, we're going to take out confounding factors. That's a randomized, blinded, controlled clinical trial, the very best research. I should do a study. If I want to look at probiotics in scleroderma patients, I would have to calculate the number needed to get an effect, and then I would power my study to have 1,000 patients in it so I get useful data. You know, a lot of these studies, they have 30 people in them. They are powered to show anything. So unfortunately, and this stuff gets published, it's not, the garbage science gets published in peer-reviewed journals, not just online. So unfortunately, it's difficult. I'm the chief educator in our section. I spend a lot of time training my physicians to read literature, read it properly, and interpret it well, and find the difficulties in it. Because the literature can harm you guys. Just as much as it benefits you, it can harm you. And so you have to be careful about how it's interpreted and how it's, I mean, again, You guys are the poster children for PPI use, because the complications of poorly controlled reflux disease isn't just bad heartburn and not be able to eat a hot dog. It's damage to the lungs. It's end-stage lung disease. That's proven. Steroids are absolutely rock solid cause and effect causes of osteoporosis. They are probably the single biggest drug as far as a causative effect of osteoporosis we've got. So unfortunately, yeah, if you had a bunch of people who are taking PPIs because their steroids were causing them to have a little peptic ulcer disease or erosive esophagitis, it would look like there's a problem there, but there really isn't. So and the reason I feel really strong about this in this group is because I see the disasters in poorly controlled reflux. Everything's risk and benefit, right? There's the risk to every drug we give you guys, there's a benefit, and you have to weigh those. And some 22-year-old who gets heartburn when she eats a Taco Bell once a month, should she be on a daily PPI? No, probably not. Some Mylanta when she goes to Taco Bell is probably good enough. For you guys who get severe strictures, who get lung disease, who get, erosive esophagitis to the point of actually getting anemic, the risk-benefit ratio isn't even in the ballpark. The risk is way down here. The benefit is really high. The only time you get interested in a drug or anything is when the risk-benefit ratio reaches unity, right? When the benefit is equal to the risk, you think about it. Maybe I don't want to do this. And there are situations where the benefit of a drug, let's take erythromycin, for instance. I see erythromycin promulgated as a treatment for gastroparesis all the time. Erythromycin has no published data to date that shows it works. It just doesn't work. It simply does not work. 10 studies. Matter of fact, they don't even discuss it anymore in review articles on gastroparesis because it simply doesn't work. Yet I see patients on it all the time. There's huge risk with that drug. The risk of it is a severe cardiac dysrhythmia that can be fatal called torsades. So I have a woman I'm fighting with in my MyChart message right now who wants to take erythromycin. I said, no, you don't. This could kill you, and there's no benefit that it works. So the risk-benefit ratio here is infinity. Tons of risk and zero benefit. Why would I want to give you that drug? And she's very mad at me right now. She says, well, how do we know it's not going to work for me? You haven't given it to me. I said, I could kill you. That's why I'm not going to give it to you. And the data shows that it's not going to help you at all. Well, some guys online said it's helping them. The placebo effect. Glad you read about that. I can find placebos for you that won't kill you. How about that? Let's go with that route. And there are options for her. It's just that she's kind of locked on to Dr. Google there. Lots of testimonials online. All sorts of people take all sorts of things and tell you how wonderful. I took this probiotic from Whole Foods and I'm cured. Got to be careful about that stuff, folks. Probiotics, not so worried about. Erythromycin, big time. Yeah.
Do you experience many Scleroderma patients that just don't respond to PPIs?
Yes. So that's an excellent question. Why would you not respond to PPIs? Excellent question. And I will admit this right now, and my surgical colleagues are always beating us up about this. PPIs are a weird way of treating acid reflux. Because what do PPIs do? They make you not acid reflux, but they don't make you not reflux. You will reflux merrily along no matter how much Nexium or Prilosec or whatever you take. They don't stop you from refluxing. They don't fix this valve. They don't improve your esophageal pump function. They don't stop your stomach from secreting anything but acid. Now, acid activates other enzymes and things that damage your esophagus, so they work for most people. But every single person I've ever treated, the thousands of people I've treated for reflux disease with proton pump inhibitors, I have never stopped them from refluxing. I've stopped them from acid refluxing. So people get symptoms from reflux. When you lie down, bile salts come up, they can hurt. Stretching the esophagus because of the bolus coming up, that can cause discomfort. So surgeons have always said, I used to get in these counterpoint lectures with Steve Milliken, one of my surgeons downtown. He says, Dr. Brown can't cure anything. He's not the right guy for your reflux. I am. I will go in there and I will tighten up your valve. And I will stop you from refluxing. And he does. He also stops you from swallowing, so he doesn't mention that. But it's a motility problem for which we give you a drug that makes you achlorhydric or without acid. Your point in particular, I'm creating a second pathophysiology. I'm creating an abnormal situation in your stomach. I'm getting rid of your acid to treat something I don't have a drug that works right for. I don't have a motility drug. They've never come up with a good motility drug. One of the depressing things about GIs, we have all these motility disorders like you guys have. I don't have drugs that are really good for them. We just don't. Doesn't stop them from trying to find them, but it seems like every time we find one, something comes up with it. Cisapride dead, Zelnorm dead, although there's some new drugs coming out that I think are going to be handy. But that's why it doesn't work sometimes. And the problem is that the solution to it is surgery, which in a patient who has poor pump function in the esophagus, doesn't have a good, squeeze, the surgeon goes in there and starts to snug up your valve, and you got this pump above it. And so they're very nervous about doing surgery on scleroderma patients because a lot of you guys have trouble swallowing after that barrier is put in place. So we desperately try to get rid of as much acid as we can so the esophagus will heal on its own. There are ways of doing this. I mean, you can do these usually they wrap the stomach like the cuff on a pair of pants to stop you from refluxing. Dr. Millick and others, they may do it only halfway, what's called a toupee procedure, or just do a little bit. So there's different ways of doing it. Dr. Chmielewski, one of our surgeons, does a little cool thing called a Lynx procedure, these little magnets. And you stick it's like a magnetic bracelet he puts around the bottom of your esophagus, and they snap shut. And when you eat, they pop open because the resistance. And they can adjust the strength of those magnets to give you magnets that are, pretty easy to open up so that your pump function, if it's still intact, can get through those things. So that's kind of a cool technique and stuff, too. So because there are alterations to these techniques, they are open a little bit. If you find a chest surgeon who does this, find someone who's done some scleroderma patients because it's tricky, but it can be done. But yes, there are people, much as I hate to say it, who fail even high-dose PPI therapy. The drugs used to increase esophageal function are poor. Baclofen, God help you, got to take baclofen. I mean, you'll just sleep through the whole day. I mean, yeah, you won't have reflux, but you won't know you have reflux because you're sleeping all day long. The drug just makes you really sleepy. And I tried people on it, because they want to give a shot at it. And I said, well, we'll give it a try. But most of them after a week have said, I can't take it anymore. I can't get to work. I'm sleeping all day. And then there's Reglan. Any of you have ever heard of metoclopramide or Reglan? It's used a lot in scleroderma patients. Reglan. So Reglan is a promotility drug. It works to increase, it does a couple things helpful in the esophagus. It can increase pump function, can help the valve tighten, helps the stomach empty a lot. That's good. However, Reglan can also cause terrible cardiac arrhythmias called torsades, which I mentioned with erythromycin, bad thing, and has one other nasty little habit of causing an irreversible neurologic condition called tardive dyskinesia, where you start to shake and you can't stop it. And you've been on Reglan for a long time and you get tardive dyskinesia and we stop your Reglan, the twitching doesn't stop, or you can get head twitching. So lots of side effects with Reglan, not my favorite drug. As a matter of fact, Reglan is probably the single most litigated drug in the United States because physicians don't tell patients of the side effects and then they get them and they get unhappy. So I'm not a big fan of Reglan or metoclopramide, but basically it's all we've got. Domperidone's another drug you may have heard about. What's cool about domperidone? Well, it can still mess with your heart, bad, but it doesn't cause the tardive dyskinesias, good. Bad news about domperidone, not available in the United States. Probably will never be available in the United States. It's available everywhere else in the world, Canada, Mexico. I think you can buy it over the counter in Mexico. You can get it in Europe, over the counter. I was in Germany. There's domperidone over the counter. However, the problem in the United States is if you write a prescription for it as a physician, the FDA has got very angry about this, and you go to jail. So it is illegal, like penalties go to jail, illegal for a physician to write a prescription for domperidone in the United States. So if you have a physician writing for it, great. You found somebody willing to take on the law, good for them. I won't do it. I don't want to go to jail, not for domperidone. So yeah, that's unfortunately, and then that's about it. Now I will, because I'm talking a little bit too much here. I will mention a new drug that I like a lot. It's son of Zelnorm. Zelnorm was a drug that went off the market, oh my goodness, maybe 10 years ago. I liked it a lot. It was really good for my scleroderma patients. Help with constipation, help with stomach emptying, even help the esophagus a little bit. It works on a serotonin receptor called serotonin receptor type 4 in the GI tract to improve motility across the board. It came out 2 weeks ago, commercially available. Matter of fact, as of 2 weeks ago, I was actually able to order it in Epic. Now, as you might imagine, it's a new drug, so it's expensive, and I'm fighting insurance companies every day about it, but it's called prucalopride. The brand name is Motegrity, Motegrity. Now, this drug is interesting, even more so than some of the other constipation drugs, because it has a more global ability to increase gut motility because it's action on these type 4 receptors. So, if you have constipation, if you have issues with small intestinal bacterial overgrowth, ask your primary care doc, your gastroenterologist about prucalopride. Looks super safe. We've seen it's been around for a long time in clinical trials. It is and has been proven to work in randomized, controlled, blinded clinical trials. It is FDA approved for the treatment of constipation. Not yet for gastroparesis or for small bowel motility issues, but since constipation is part of the issue anyway, you kind of get a two-for with prucalopride that you won't get with other drugs for constipation. You're going to get the good colonic motility out of the deal, and you'll perhaps get some nice small bowel and gastric motility. So a nice drug for scleroderma patients. It will start to get studied in scleroderma patients now that it's more widely approved. You know, drug companies, hate to say it, but their bottom line is a big deal for them. They like to make money. So they like to study things where they can sell a lot of drug right away, right? So they're going to look at constipation because that's huge. Scleroderma, not so much. You know, 240 people per million isn't a huge number of people. But it'll trickle down into being studied in scleroderma. And I think based on the older Zellnorm data, I think it looks really promising. So as long as your doc is willing to say, oh, there's some constipation here we're treating, I think you'll be able to get it approved by your insurance company. And it's certainly a new drug worth a try. 2 weeks ago, it just became commercially available. So the problem with when you turn the small bowel into a transit organ, you got troubles. The main trouble is small intestinal bacterial overgrowth called SIBO. Probably heard about that. Scleroderma patients have a lot of trouble with SIBO. It's the biggest single problem in the small bowel, and it pretty much leads to all these other things. It leads to pseudoobstruction, it leads to, well, not so much pseudoobstruction, but it leads to pneumatosis, ostoides intestinalis, little blebs of air in the wall of the bowel. It leads to malabsorption of nutrients. I'll show you how here in a minute. Hopefully I got the right slide next. Here we go. So, up top, that's normal distribution of bacterial flora. So if you don't have scleroderma, you're probably like up top there. So over here, down in the colon, yeah, lots of bacteria, but who cares? By the time the food gets down there, this is stuff you don't want anyway. And they can chew up the carbohydrates you don't want to absorb, and you make gas, because we all make flatus, right? 2 liters a day for everybody. So not a big deal. And notice up top here, those smaller little beads, that's the normal carbohydrates that you should absorb completely in your small bowel, never get to the colon, never get turned into gas, never get turned into smaller carbohydrates that cause diarrhea, and you do well. This is bacterial overgrowth. What's happened in a scleroderma patient here, because of abnormal motility, the bacteria have grown all the way up into the middle or upper small bowel. So now when you eat foods like, let's say, white rice, which should be completely absorbed in the small bowel, before it even makes it to be absorbed, your bacteria are fighting you for it. They're digesting it themselves. They're taking the nutrients out of it and not allowing you to get them. And it's not just like easily digestible starches, it's vitamins. Water-soluble vitamins, B vitamins, B12, C. Fat-soluble vitamins, vitamin A, vitamin D, vitamin E. I'm a fanatic about vitamin D in my scleroderma patients. I'm checking it all the time. And it's a battle sometimes to get it up. But when it comes to chronic pain, you want your vitamin D level as high as you possibly can get it. Fooling around at a 30 microgram per deciliter level of vitamin D, just barely normal, not good enough. You want your vitamin D in that 50-60 range, because low vitamin D levels are associated with low pain thresholds. So if you have chronic abdominal pain, chronic joint pain, there have been studies showing that the higher your vitamin D level, the better you are. And of course, we live here where, you're not going to get vitamin D today out there. So there's no sunshine. You've been inside all day. You work in a windowless cubicle. No sunshine for you. Your vitamin D levels in the winter can be tragically low. So keep an eye on your vitamin D levels at least every 6 months. If it's below what we call, if it's in deficiency range, below 20, then we really give people very high doses, 50,000 units of vitamin D a week, every week for 8 weeks to get it up. And then we're going to put them on 2,000 to 4,000 international units. So your little bottle of 1 a day, that's about 400 units of vitamin D. If you're taking Oscal with vitamin D, 400 units. You need about 10 times more than that, 2,000 to 4,000 units of vitamin D. Do not worry. I have never seen a scleroderma patient able to get vitamin D toxicity at those levels. It's just not possible. But I can get them up into that 40, 50 range with those kind of levels. I take 2,000 units a day. I was embarrassed I went to the doctor at the beginning of April, and I had my vitamin D level checked, figuring I'm going to look heroic. I'm taking 2,000 units a day. I was 30. I was barely normal. That's because I'm in the dark all day in my endoscopy lab. I don't see any sunshine. So nothing, I don't have any native vitamin D. I have to get it all by pills and I don't drink milk, so I was in trouble. So I was really kind of embarrassed by that. I thought I'd really have a good level. So it's tough. That's the one vitamin I'd spend some time and effort looking into. Talk about osteoporosis, you know. Again, the vitamin D calcium thing in preventing osteoporosis and sclerosis isn't quite clear, but there is certainly no harm in having a nice vitamin D level. And you guys are definitely at risk for low A and E, you know, the levels in most of my scleroderma patients are okay. It's the D I worry about a lot, and I do check that. And by the way, there's one other little micronutrient that probably your primary care doc's not checking that I would: zinc. Check your zinc levels, because malabsorption and inflammation cause zinc levels to drop. And we know zinc levels very important in healing inflammatory responses. It's a very important micronutrient. And so if your zinc levels are low, which you may be surprised to find yours are pretty low, then a simple 30 to 50 milligram daily zinc supplement will do the trick. And again, what you get in your multivitamin ain't going to do it. So if I have to give you some advice today of things to sort of push your primary care doc about, it'd be making sure you get that vitamin D level checked, and routinely check at least once a year, check that zinc level. And if you're on a PPI, once a year, magnesium. The reason for magnesium is magnesium helps you use calcium properly. So going back to osteoporosis and osteosclerosis, having good mag levels is a good thing too. So I'll leave those 3 things for you to remember: zinc, magnesium, and vitamin D. So anyway, the reason we get into trouble with bacteria, we're going to go past that. This is pneumatosis intestinoides. So it's we get into it with the colonoscope. You see all these blebs of air. And it's because you have bacteria growing in the bowel that are basically causing air to accumulate in the wall of the bowel. It looks more scary than it is. And actually, we just put patients on very high levels of oxygen, and this air will come out of the wall of their gut. But it looks kind of scary on endoscopy. But it's really a pretty harmless condition, but indicates bacterial overgrowth and scarring. The colon. The colon's a bit of a problem child. You know, the colon isn't as vital as your small bowel and your stomach are, but when it starts to plug up things, it can be uncomfortable. As I mentioned, constipation's the main sort of symptom we see in patients with scleroderma. You can get colonic pseudoobstruction, where you get these massively dilated the air in that colon. That's pretty uncomfortable. Those are not pictures from a scleroderma patient. That's from a patient who had sort of a myopathy that affected her colon. But yeah, you can end up with these obstructions and at least a lot of severe constipation. There are lots of drugs on the market now for constipation that I didn't have when I started talking to you guys like 10 years ago. So there's Amitiza, there's Trulance, there is Linzess, and really now my favorite for scleroderma patients is probably going to be Motegrity, the one I mentioned to you, prucalopride, just because you get a little more bang for your buck in the upper digestive tract that you won't with the other ones. But they're all pretty good. They work well. Here's what I would not do. So the issue in scleroderma is slow transit. So the colon is just not moving great. It just, the efforts to push back are very strong, and the efforts for pro-motility, sort of propagating waves, have been damaged. Fiber. Everybody thinks the 3 things to do to treat constipation, what we euphemistically refers to as the preached trio, is drink more water, get more exercise, eat more fiber. I don't have any data that any of that works. So if you drink more water, it will be completely absorbed by your small intestine, and you'll urinate like crazy. You'll have totally clear urine, good for you, but you will not get 1 drop into your colon. You have 22 feet of small bowel. If I laid it out 1 cell at a time, if I smushed it out, it would cover 3 tennis courts. Imagine taking your, I don't see anybody, no millennials here, I don't see those ubiquitous, well, there's 1 water bottle. Whenever I give a lecture to the med students, I look up and it's laptops and water bottles. They drink water like crazy, which is great. And they absorb it in their small bowel, which is great, nothing wrong with that, but it isn't going to make your colon. If they took that whole bottle and just threw it out over a tennis court, there'd be nothing dripping off at 3 tennis courts down the road. There's nothing left. It'd all be absorbed by the concrete. So same thing with water. Doesn't work. Water works when you drag it to the colon. So the water magnets are things like Miralax, lactulose, which is not my favorite drug, but Miralax is pretty good. Milk of magnesia. Basically pulls water molecules through the small bowel, brings it to the colon, and helps soften and make it easier to pass stool. So those are called osmotic laxatives. They work nicely. But water by itself will make you have more bowel movements. Exercise is the one that cracks me up. I exercise all the time, and when I get off my exercise cycle, I don't feel like having a bowel movement. I just don't. There's no stimulus for me to go to the bathroom when I ride my exercise cycle. And it's just the opposite. Think about that for a second. When you're on your exercise cycle, where do you want your blood going to? Your colon? Why? No. Heart, lungs, brain, muscles. It gets taken away from your gut. Your gut slows down, it goes into lockdown mode, it slows up. Exercise is constipating, it is not a pro-motility approach. So you could run the marathon, well, if you ran the marathon, you might get diarrhea from just cutting off the blood supply to your colon, but that's not the way to have a bowel movement. So it doesn't work. And fiber, that's my least favorite one, because you guys have a higher risk of the bacterial overgrowth. So if you put a non-absorbable fiber into a bowel that already has a high risk of overgrowth, you're going to bloat like crazy. Giving a patient with scleroderma fiber for their constipation is almost like being mean to them. It is not a pleasant thing to do to somebody. It's just going to ferment like crazy. It's going to get stuck in there because it's a bulking agent, right? So this is not the way to do it. So the way to do it is Miralax and Milkamania. Those are fine ways of doing it if you don't want to use a prescription drug, because they don't ferment, right? And they're water magnets. So drink your big bottle of water, take some Miralax, nice bowel movement, no gas, everything works well. Or take something like, again, Motegrity, Linzess, those work fine. Forget the fiber. Whatever you get in your daily fiber, unless you're, a meatitarian and you're just on a, low-carb diet, you're probably not going to get enough fiber for a patient with scleroderma. Don't overdo it. I see a lot of that in my clinic where the patient's just, every time I go to the doctor, she tells me I got to drink more water. I'm eating cardboard. I'm running a marathon. I'm drinking a gallon a day, and I'm not having more bowel movements. And then what do? They turn it back on you. Well, you must still not be eating enough fiber, getting enough water, getting enough exercise. So that just doesn't work. And particularly in scleroderma, because of the risk of bacterial overgrowth, fiber is particularly problematic. So don't spin your wheels on that. Luckily, liver disease is rare in scleroderma patients. The only thing we really ever see is this thing called primary biliary cirrhosis. It's thickening and scarring of the bile ducts, which, not too surprising given what we know about how scleroderma affects smooth muscle. But very rare, 1%, almost never leads to liver transplant, very slow progression, very mild disease compared to the sort of idiopathic or native version of this disease. So I have never in my 30 years at Rush had a single scleroderma patient go to surgery for PVC. Usually sometimes they get a little itching with it, and we might treat that with cholestyramine, et cetera, but otherwise, or ursodeoxycholic acid to sort of reduce the itchiness from the bile salts. But otherwise, don't really have too much trouble with that one, which is good. So let's see what time. I don't want to get too crazy. We've got a little time. I'm going to quickly go through some testing. This is what I like to test in my scleroderma patient when they come to the office. This is the blood work. And you might need to ask for this because this isn't in your routine screening panels. So vitamin C, particularly if you have skin involvement, check your vitamin C level, make sure that's up to snuff. I do these every 3 to 6 months. Selenium is another micronutrient along with zinc that may be important in inflammatory conditions, so have them check a selenium level. Even more important than selenium, though, as I mentioned, was my zinc. I love zinc. I like zinc levels up, so check that one, and I find it low oftentimes. And my other favorite one's vitamin D. The water-soluble vitamins, pyridoxine associated with sort of neurologic issues, tingling and peripheral neuropathy. So maybe once a year, check your B12 and your B6 levels, and then folate. Now, the interesting thing about folate is that sometimes patients come in and all these levels are low and their folate is skyrocketed very high. It's like, why would all these other ones that indicate some small bowel malabsorption be low, but folate, which we know is absorbed in the small bowel, is low? And it turns out that if you have bacterial overgrowth, there's one single good thing that extra bacterial load does for you. They make folate. So when you don't absorb your nutrients, the bacteria absorb your nutrients, and guess what? They make one little gift for you. They make you folic acid. So you'll have, if you ever come back and your doctor says, oh, the other things are low, but boy, are you taking folate supplements? It's like 10 or 20 or something like that. Well, bingo. That's a crude sort of a little cheap way of diagnosing the fact that you probably have bacterial overgrowth, that folate level is very high, and then you might want to get into treatment for that. Upper endoscopy, I do a lot of endoscopy, not overly helpful in scleroderma patients because you can't see motility really well, but if you have obstructions like a stricture, then yes, that's the way to get that fixed up. And we do it for, to look for evidence of erosive esophagitis and such, but not an overly helpful tool. You guys do not have an increased risk of colon cancer. Good. You still need your colonoscopies at age 50, every 10 years or so, but there's no extra need for colonoscopy. And of all the tests I do in patients, there is no more useless test for a constipated patient than colonoscopy. Absolutely worthless. Yet I will tell you, a lot of gastroenterologists You come in with constipation, they're going to colonoscope you. They'll never find anything because it's not a structural issue. But they do that test a lot, and then they kind of throw their hands up and it's normal. But yeah, there's no particular reason to do a colonoscopy for constipation, but to look for polyps and such, it's fine. This one we do a lot in scleroderma. In fact, I make the diagnosis of scleroderma by this test alone oftentimes. This is a high-resolution manometry test, a way of measuring the propulsive activity of the esophagus. And it's really cool. What you're looking at here, these strips are basically swallows. And what you're looking at where it's red, that's high pressure. And then you're seeing a person swallowed up here. There's a good contraction. And then you see her bolus of food moving on down here to her stomach where her valve here relaxes. So there's a relaxation of the valve. And the food bolus, you can see there's pressure waves. It pressurizes as the food moves through the esophagus. So that's a normal motility study there. Do a lot of those. They're good. They're helpful in making the diagnosis and following, any improvements. They're very useful preoperatively, but we usually mostly use them to make a diagnosis of scleroderma oftentimes. There's a classic motility abnormality in a scleroderma patient, and that is this part, the upper third of the esophagus, because it's innervated with, it has skeletal muscle, works great. And the bottom 2/3 is not moving at all. And you will never see that in any other condition. It's so pathognomonic, meaning so classic for scleroderma, it's actually called scleroderma esophagus or a scleroderma motility tracing when we see it. And I've made the diagnosis that way many times. This is pH testing. It's kind of cool. Remember when I told you how we found out that if you sleep on your left side, you do better? This is how we figured it out. We put these little buttons in there, and they stick in your esophagus for about 4 or 5 days, and they hang on for dear life, and they're measuring acid as it comes up. It sends a radio signal to that little pager-like thing you wear in your belt, and then you have little buttons you push on it to tell me when you're having heartburn or reflux. When you come back, you give me the box. I download the box to the computer. It downloads all the acid data, showing me how much acid's in your esophagus and when, and it shows me when you push the button, indicating you have pain. So I can measure the absolute amount of acid in your esophagus, and I can see if it correlates with your pain. This is a very useful test in scleroderma patients, and we do it quite a bit. The little capsule falls off, passes in the stool. We never want to see it again, but it's kind of cool. Sometimes we do imaging studies just to look for strictures or narrowings, just to make sure that if the small bowel is obstructed, to make sure there's no structural obstruction. We do contrast studies of the small bowel, like a barium X-ray. But their need is diminishing with CT scans. Do a lot of CT scans. I don't mind CT scans. They give you a lot of information. I mind a lot of CT scans because CT scans, just to give you a quick little radiation physics lecture, is the equivalent of 100 chest X-rays in radiation. That's a lot of radiation. So don't become a little bit of a victim of modern, what we call it vomit, victim of modern imaging technology. If you have the same kind of pain for a long time, then getting CAT scans all the time is a little bit, not only a waste of money, but a little hazardous. You really don't need that much radiation. So basically, CAT scans are good, get a lot of information from them, but repeating them over and over, gotcha, 5 minutes, for the same symptom is pretty unhelpful. Hydrogen breath testing is a way of just call it the birthday test. You come to my office, I give you special sugar to eat, you blow up balloons. Pretty simple test. But in the balloons, I'm looking for hydrogen gas that indicates that the bacteria are breaking down the carbohydrate for you, indicating bacterial overgrowth. Super simple test, pretty accurate. I won't spend much time on ultrasound, don't do much of that. I do want to get really quickly, because I'm running out of time, into treatment. So I mentioned the stuff about sleeping. Don't eat before you go to bed. Don't smoke. Oh, please don't smoke. Proton pump inhibitors work much better than the Zantacs of the world. And the problem with Zantac and Tagamet, they work pretty well. They're not as aggressive in suppressing acid, and they have a high resistance rate. So over time, they conk out. So I have a lot of physicians who say, oh, I'm scared of PPIs. I'm going to put you on Zantac. Well, that's fine for about 8 weeks, and then it's going to wear out. You're back on the PPI anyway, so not my favorites. The prokinetics I mentioned, the only one available is our dear friend metoclopramide. If you are on metoclopramide, 2 things. If you get twitchy, call your doctor, stop the drug. If you get twitchy, your hands start, you're kind of writing and your handwriting is starting to change, or you're watching TV and things are moving around, talk to your doctor about tardive dyskinesia. Every 3 months, if you're on metoclopramide, get an EKG. ask your doctor to make sure something called your QTC, it's called the QT interval, the corrected QT interval, QTC, has not prolonged. If your QTC, and you're a woman, is getting above 0.45 milliseconds, stop the drug, because you're at risk for this fatal cardiac arrhythmia, and that's not a good thing. If it's fine, great, stay on it, no problem. 2 things, watch for tardive dyskinesia, get your every 3-month EKG if you're on Reglan, otherwise go ahead and use it. So, we're talking a little about new esophageal treatments. Yeah, medical marijuana. So, how do you get marijuana approved? You have to have randomized controlled clinical trials that show the state of Illinois the drug works. That's why it's about to be approved for opiate patients who need opiates for pain control. That opens up a huge class of people. It's about to be approved for irritable bowel syndrome. Believe it or not, it's going to get approved for IBS before Scleroderma got, which is really frustrating, but that shows you the power of studies. It's already approved for Crohn's disease, and I use it a lot in Crohn's patients. So I agree, I think this has a role in Scleroderma, in improving gut motility, reducing nausea, vomiting, and improving pain. But it's going to take some more studies to get it there. Acupuncture works pretty well, so there's those options too. So on the sort of alternative medicine side, I'm not going to spend too much time on this. We don't do much of this. Let's see. Botox. I'll mention that really quickly. You know, the data's a little flaky on putting Botox into the valve at the base of the stomach to help it open up and drain. Some studies say yes, some studies say no. Super benign intervention. I think 100 units of Botox costs about $395, so it's not a break the bank kind of thing, and it's just a one-time shot anyway. I've had some success with that. The literature on it is, ups and downs, but very safe to do, very easy to do, and might help with your gastroparesis if the Reglan, et cetera, is not doing the trick. Intestinal treatments, mostly for bacterial overgrowth, it's going to be rotating antibiotics. So for my Scleroderma patients, get a week of doxycycline. Next month, it's a week of Xifaxan. Next month, it's a week of Augmentin. Next month, it's a week of metronidazole. The caveat on antibiotics is you need them, a week a month, and that'll do the trick. Keep things at bay. Cycle them, right, so that you don't get resistant. You should have 4 in your cycle if you can tolerate them. Do not use Cipro or Levaquin. Please avoid Cipro and Levaquin. I don't know why this is not filtering down to a lot of doctors, but the FDA has sent out at least a half a dozen warnings about those drugs. They are now last resort drugs because they can cause a permanent peripheral neuropathy. I see them used in Scleroderma patients all the time, so I'm going to give you this heads up. There's just 2 weeks ago, they put out a warning that they increase the risk of fatal aortic dissection. That's not good. Number 2, they can cause a permanent peripheral neuropathy. That's not good. Number 3, they can cause your Achilles tendon to rupture because they damage the tendons and connective tissues. That's terrible in the Scleroderma patient. That's no good. They have been associated with, so I'm going to an association here, but it was enough to concern the FDA with worsening cognitive decline in Alzheimer's patients. And finally, if you're diabetic, they can make your diabetic control problematic. There is no reason on God's green earth to take Levo or Cipro anymore. I would never personally use those drugs myself. I never give them to any patients. The FDA came out and said there are only 2 conditions in which you should be using Levo and Cipro: anthrax and bubonic plague. That's pretty low stuff in the United States. So I'm going to tell you that so that you can beg your doctor for anything else. There's lots of alternatives. So in Scleroderma in particular, the last thing you need is an Achilles tendon rupture. Do not take Cipro or Levo for a year. And I'll make one quick comment, and I'll shut up here real quick. This is a good diet for gas and bloating and constipation. It's called a low FODMAP diet. You've probably heard about it. If you want to do a low FODMAP diet, and if you have a lot of bloating and gas and constipation, I would recommend it. It seems to work pretty nicely. Talk to a dietitian. It's not an easy diet to do, and it should be modified so that the fermentable carbohydrates that are removed from your diet are specific for your microbiota. It's dangerous to be on a low FODMAP diet forever. It's safe to be on a modified low FODMAP diet, meaning one that's tailored to you by a dietitian. He or she will take away all your FODMAPs, and then they'll introduce them one at a time over a couple of months. And you'll tell her that was a bad week, it was a good week, bad week, good week. At the end of 8 weeks, your low FODMAP diet will look very different than my modified FODMAP diet or anybody else's in this room, which is fine. Don't do a low FODMAP diet. Your gut needs some FODMAPs for its health. You just want to pick the ones that are very gassy for you, basically, which means, your microbiome will like them a lot. So do it with a dietitian. And they're really good at it. They know how to do FODMAPs. The data on this diet is extremely good. 35 published randomized controlled clinical trials showing that it helps with abdominal pain, bloating, constipation. So if you're going to pick a diet in Scleroderma, that's the one I choose. And I will now be quiet. So thank you very much.